Welcome! In this video, we'll explore the scapulothoracic joint, a crucial structure for shoulder movement and stability. Understanding its anatomy and function is essential for therapists and anyone interested in musculoskeletal health. We'll break down the joint's type, surfaces, and the unique way it moves. Whether you're a student, professional, or just curious, this guide will provide a clear, step-by-step overview. Let's begin by understanding what makes the scapulothoracic joint special and why it's so important for upper limb mobility. Let's start with the therapist's positioning and grasping techniques. The therapist stands behind the patient, facing the acromioclavicular joint. The left hand's thumb is placed over the lateral end of the posterior clavicle, while the fingers grasp the anterior side. This precise positioning ensures effective mobilization and patient comfort. Proper hand placement is key to achieving the desired joint movement and avoiding unnecessary strain. Mastering this setup lays the foundation for all subsequent scapulothoracic joint techniques. The scapulothoracic joint is classified as a fibrous joint, connecting the anterior surface of the scapula to the posterior ribs. Unlike many other joints, it lacks traditional ligaments, relying instead on muscular and fascial connections for stability. This unique structure allows for a wide range of motion, making it essential for shoulder elevation, depression, protraction, and retraction. Understanding these basics helps us appreciate the joint's flexibility and its role in upper limb function. Let's dive into the movements of the scapulothoracic joint. Osteokinematics here mirror those of the sternoclavicular joint, allowing for elevation, depression, protraction, retraction, and both medial and lateral rotation. Arthrokinematically, these movements involve cranial, caudal, medial, and lateral gliding of the scapula over the ribs. This versatility is crucial for complex arm movements, such as reaching overhead or pulling objects toward the body. Proper positioning is vital for both assessment and therapy. The starting and resting positions involve the clavicle being horizontal, with the scapula spanning ribs 2 to 7. Interestingly, the scapulothoracic joint doesn't have a true close-packed position or a defined capsular pattern, highlighting its unique anatomical features. This flexibility allows therapists to adapt techniques to each patient's needs. Distraction is a foundational technique for increasing joint play and reducing pain around the scapulothoracic joint. The patient lies on their side, facing the therapist, with their upper limb supported on the therapist's forearm. The therapist's left hand fixes the acromioclavicular joint, ensuring stability. This setup prepares both patient and therapist for effective mobilization, setting the stage for specific gliding techniques. For distraction, the therapist stands in front of the patient, facing the scapulothoracic joint. The right hand fixes the acromioclavicular joint, while the left hand grasps the inferior angle of the scapula. The therapist then gently pulls the scapula away from the rib cage, creating space and reducing discomfort. This technique is especially useful for patients with restricted movement or pain in the upper back and shoulder area. Cranial gliding is performed to enhance joint play, reduce pain, and increase scapular elevation and lateral rotation. The patient remains side-lying, with the therapist's left hand fixing the acromioclavicular joint and supporting the patient's upper limb. The therapist's left hand then performs cranial gliding, moving the scapula upwards while maintaining distraction. This technique is particularly effective for improving overhead reach and reducing stiffness. Caudal gliding targets increase joint play, pain reduction, and improve scapular depression and medial rotation. The patient remains side-lying, with the therapist's left hand fixing the acromioclavicular joint and supporting the upper limb. The therapist applies a downward or caudal force to the scapula, encouraging movement and flexibility. This technique is ideal for patients struggling with downward arm movements or tightness in the upper back. Medial gliding is used to increase joint play, reduce pain, and enhance scapular retraction, medial rotation, and depression. Unlike previous techniques, no fixation is needed. The therapist uses both hands, one over the acromion and the other over the inferior angle, to glide the scapula medially. This movement is essential for activities that require pulling the shoulder blades together, such as rowing or posture correction exercises. Lateral gliding focuses on increasing joint play, reducing pain, and improving scapular protraction, elevation, and lateral rotation. The therapist stands in front of the patient and uses both hands, with fingers spread over the medial border and thumbs on the lateral border, to glide the scapula outward. This technique is particularly beneficial for reaching and pushing movements, as well as for patients with limited shoulder mobility. Having covered the essential scapulothoracic joint techniques, let's transition to the shoulder joint itself. The shoulder, or glenohumeral joint, is a synovial ball and socket joint, formed by the concave glenoid cavity of the scapula and the convex head of the humerus. Understanding the relationship between these joints is key to comprehensive shoulder therapy and rehabilitation. In the next section, we'll explore the shoulder joint structure and function in greater detail.